So thanks for coming. I realise it's a particularly eventful day, so I'm grateful that you were able to drag yourselves away from the news and the doom scrolling for an hour or so. For those of you who haven't met me, I'm Siobhan O'Dwyer. I'm a senior lecturer in ageing and family care at the University of Exeter Medical School. So today's session is about understanding the evidence on suicide and homicide risk in family carers. So it's based on a review of the international evidence that my colleagues and I recently conducted, and it includes recommendations for research, policy, and practice. I know we've got quite a mixed group today of health and social care professionals, researchers, policymakers, and even some carers. So I hope there'll be something for everyone to take away. In that time when we're talking and reflecting and sharing, it may be that it's appropriate to share an experience that you're aware of or something you've encountered in your research or in your policy making or your clinical practice. And I would love that. I really welcome that. But just a reminder, if we can respect the anonymity and the confidentiality of our clients, our patients, or our participants as we're sharing those stories, that would be great. Also, if you're a carer, this is probably not the best place to share your personal experiences of suicide and other things, but my contact details will be on the slide at the very end. I'm really happy to make a time to talk one-to-one with anyone who wants to share a personal experience with me. The other thing to say is, again, this work and things we're going to talk about today can be triggering in ways that people don't often expect, or at moments that people don't expect. So if you need to step away, that's totally fine. The session is being recorded, so you can always come back and watch it later, or take a break and come back in a few minutes' time. Also, if you do need urgent support, the number for the Samaritans is there on the screen, 116 123. They're fantastic. If making a phone call is not an option for you, there's also a great text-based support service. If you text the word shout to 85258, you can have a conversation in the same way that you would with Samaritans, but just by text message. So we'll crack on then. So the aim here is really, in this session, is really to introduce you to the evidence on suicide and homicide risk in carers and highlight how that might be relevant to your work, whether that's in research or practice or another setting. So I'll introduce you first to some of the people that I work with, because none of this work happens individually, it all happens as part of a team. I'll talk you through this review that we recently conducted and what we know, also what we don't know. Then I'll work through the recommendations in each of those three areas. Then lots of time for questions and comments and reflections. And then I'll talk a little bit at the end about future direction. So where are we taking this research now? How are we starting to implement it in practice? And what might you be able to do in your own spheres to start putting some of this in place as well? So these beautiful people are the lovely people that I have the privilege of working with. So I'll start with me. So as I said, I'm Siobhan. I'm a senior lecturer in the medical school here at Exeter. I'm a psychologist by training. I spent several years working in the third sector, and my research is focused on a range of issues in ageing and care. But for the last 10 years or so, I focused really specifically on suicide and homicide in unpaid carers. I won't go through each of my colleagues individually, but just to say, our team includes social workers, psychiatrists, medical sociologists, education specialists, family therapists, and also 4 carers who are co-investigators on both the review, but also some current work that we're doing, which I'll talk about a bit later on. And I just want to highlight that these 4 carers are at the heart of everything that we do. Nothing that we have done in this space happens or could ever have happened without their involvement, and they've really been the key to making sure that this work is meeting the needs of carers, and it also done in a way that is safe for carers who've had these experiences. So we're really lucky to have them as part of the team. Before I talk about the review that we conducted, I wanted to set the scene and provide some justification for why we did it. So why study suicide and homicide in carers? There are 9 million family carers in the UK, and there's a few different terms here, so I just want to clarify. I often use the term family carers. You might be more familiar with the term unpaid carers or informal carers. If you worked outside the UK, you might use the term caregivers. Essentially, what we're talking about today is people who provide unpaid care for family members or friends with long-term illnesses or disabilities. So we're not talking about professionals or paid care workers. Although unpaid carers sometimes receive benefits, they aren't paid a salary or a wage. So that's where the unpaid care bit comes in. And we usually talk about them as family because they have a long-standing personal relationship with the person they care for, usually as a partner, a parent, an adult child, or sometimes a close friend. So there's 9 million of them in the UK, or there were before COVID. Some recent estimates suggest that now it might be closer to 13 million. And their unpaid labour is estimated to be worth £132 billion a year, which is just shy of what it costs to run the NHS. So carers are effectively a second NHS. They are the invisible scaffolding that holds up our community. And if they stopped doing what they do for even a day, health and social care in this country and around the world would grind to a halt. But despite this really significant social and economic contribution, we know that caring takes a serious toll on the well-being of carers. There's about 6 decades of research that shows that carers experience higher than average rates of physical and mental illness, social isolation, and financial distress. More recently, there's also been evidence emerging to suggest that the pressures of caring also lead some carers to think about suicide and homicide, and sometimes to act on those thoughts. And I want to talk briefly here about the language as well. So suicide, obviously, most of you will understand, is thinking about or acting on thoughts of killing yourself. Homicide in this context is thinking about or acting on thoughts of killing the person for whom you care, if you're an unpaid carer. And the use of the word homicide here is really deliberate. So we're not using terms like murder or mercy killing or assisted suicide. Those terms carry a judgment. They also often carry really incorrect assumptions about the motives behind these thoughts and acts. So the term homicide is a very objective term that just talks about the act. So that evidence has been emerging over the last few years that carers might be a high-risk group for suicide and for homicide. But no one's ever synthesized it. No one's ever brought it together and said, okay, if we look at all this research that's been done, what do we know about suicide risk in carers? So that's where my team and I came in. So what we did was we conducted a scoping review of the international literature. So our aim here was to identify all the evidence on suicidal thoughts, and you might hear this referred to through the presentation as suicidal ideation, but it's basically thinking about suicide. So all the evidence on suicidal thoughts, suicide attempts, and deaths by suicide in unpaid carers. We also wanted to identify the factors that put carers at risk of suicide and make evidence-based recommendations for how carers in crisis would be better supported. We deliberately kept our review really broad, so we didn't put any limits on the type of research that was done, the relationship between the carer and the care recipient, the type of disability or the country. We kept a really broad focus. And although we were focused specifically on suicide risk for this review, we were also open to evidence on homicide as well. And so I'll share some of that as we go through. The research that we looked at, we focused just on unpaid carers who were aged over 18. So everything you're going to hear this morning is about adult carers, but there is also a very small but growing body of evidence that suggests young carers may also be a high-risk group for suicide. And we only looked at peer-reviewed journal articles, but there's also a lot of anecdotal evidence, media reports, court documents, serious case reviews, things like that, that really confirm everything that we're seeing in the academic work. For those of you who sit in a more clinical role, it's worth noting that we were only interested in here in people caring for family members with long-term illnesses or permanent disabilities. So we excluded acute illnesses or conditions. We also excluded Munchausen's by proxy or fabricated illnesses. Obviously, the caring role in that situation is very different. And studies of caring for older adults where there wasn't a specific illness or disability mentioned. And we obviously excluded studies that were about euthanasia or physician-assisted suicide, because again, a very different phenomenon. And we only looked at studies published in English. So what did we find? In our review, there were 48 studies, including 7 from the UK, that reported suicidal thoughts and behaviours in unpaid carers, with most of them published in the last 10 years. And I should note here that our review was published last year, and since then there's been another 10 or so studies published, including a report from the CDC. So this is really a growing area of research interest. The studies are mixed in terms of their methods, so quantitative research, qualitative research, case reports, also reflections of health and social care professionals. They span low, middle and high income countries. So some examples include research from Zimbabwe, Brazil, Japan, Australia and the Netherlands, amongst many others. They also cover a range of illnesses and disabilities in the people who were being cared for, including cancer, dementia, HIV, schizophrenia, quadriplegia, Down syndrome and cerebral palsy, just to name a few. So the number of carers reporting suicidal ideation varies across studies, with some estimates as high as 71%, so 71% of carers saying they've thought about suicide, and most reports likely to be an underestimate because of the way the question was asked or reported in the study. And I won't dwell on issues of measurement now, but I'm really happy to talk about that later if people are interested. Among carers who had contemplated suicide, some studies reported that 1 in 6 carers said they would attempt suicide in the future, and 1 in 10 had already attempted suicide. What we also see from this research in carers' suicide plans and attempts is the use of high lethality methods. So these are methods of suicide that have a high likelihood of resulting in death. And this is a really important point because what it should do is dispel any myth that carers' thoughts of suicide aren't serious or that they're too altruistic to act on them. So I've gone through that quite quickly. So I just want to repeat those key findings at the end there. So in some studies, as many as 71% of carers said they had thought about suicide. That's more than 2/3. And of the carers who thought about it, 1 in 6 told researchers that they were likely to attempt suicide in the future, and 1 in 10 had already attempted. These, as far as I'm concerned, are deeply troubling findings, and we should be really concerned about these. There aren't any, there haven't been any quantitative studies on homicidal ideation, so thoughts of killing the person being cared for. So I can't provide any percentages or numbers around that. But there is clear evidence in the qualitative research that some carers also think about homicide or homicide-suicide, so killing the person they care for and then killing themselves. There's also currently no systematically collected evidence to indicate how many carers have died by suicide or homicide-suicide, but the high rates of suicidal thoughts and extensive anecdotal evidence on deaths provides sufficient imperative for urgent action in policy and practice. So I guess the summary point for this slide really is that although there are some gaps in our understanding and we absolutely need more research, the review shows that there is enough evidence to say very firmly that carers do think about, attempt and die from suicide and sometimes from homicide-suicide, and that this is a universal phenomenon that's not unique to any particular country, illness or disability. So in the review, we also wanted to understand the factors that make carers more likely to think about suicide and the factors that might prevent them from reaching that point. So I'm going to talk through some of these now. It's worth noting, though, that because of the nature of the research that's been done, these are mostly risk and protective factors for suicidal thoughts. There may be additional risk factors for attempting or dying by suicide. So what you can see on this slide here, the top group of dot points are the risk factors that we see really consistently across all the studies. The bottom group of dot points are the protective factors that we see really consistently coming out through all the studies that have been conducted. The ones on this slide are from the quantitative research, but I'll also talk you through some additional findings from the qualitative research as I go through. So as you would expect, depression and anxiety make carers more likely to think about suicide, as do dysfunctional coping strategies. So what I'm talking about here is things that might seem helpful in the moment, but long-term are harmful. So things like drinking too much, substance misuse, overeating, undereating, over-exercising. So carers who are using dysfunctional coping strategies are more likely to think about suicide. Carers who are dissatisfied with their role, their caring role, whether it's the amount of care they're providing, the type of care they're providing, or even the fact that they're caring at all, are also more likely to think about suicide, as are carers who have limited social support. We also know from the qualitative research that carers who feel trapped in the role and who are desperate for an escape or a reprieve are more likely to think about suicide. And we know that carers who are in conflict with health and social care professionals or family over the caring role or the needs of the person they care for are also more likely to think about suicide. In terms of protective factors, we know that older carers and people caring for older family members are less likely to think about suicide, as are carers who have more reasons for living. So reasons for living is a measure that's used in a lot of suicide research that says, if you were thinking about killing yourself, what might stop you? And so the responses include things like, I wouldn't want to leave that legacy for my children or my grandchildren, or I'm afraid of the pain or the violence, or my religion forbids it, things like that. So carers who have more of those reasons to stay alive, less likely to think about suicide. Also, carers who score higher on measures of optimism are less likely to think about suicide. And then we also saw across all of this research that carers who were employed, carers who had a paid job or had a volunteering role, were less likely to think about suicide. And this is a little bit counterintuitive. If you know anything about carers, you know that it's often a 24/7 job for years on end. So how possibly could going out to work or being a volunteer make that easier? What we think is going on here is that in having a job, having a volunteer role, gives you an identity beyond your caring role. It gives you a sense of self and a sense of purpose and meaning that is more than just this relentless caring role. Obviously, employment and volunteering also provide vital social support. And in the case of employment, obviously a stream of income that can be incredibly helpful for carers. From the qualitative research, we also see that having a faith is protective. Doesn't necessarily mean having a religion, although for some carers it absolutely is a religion. For other carers, it's more of a spirituality or a general faith that seems to be associated with a lower risk of thinking about suicide. Now, most of this, for those of you who know anything about suicide, a lot of these things are really consistent with what we'd see in the general population: depression, anxiety, lack of support, things like that. But there are some risk factors here that are unique to carers. So that dissatisfaction with the caring role, that feeling of being trapped in the caring role, and the conflict with professional care providers or family members about the caring role, these are unique risk factors for carers. I also want to make a comment here about depression. So depression is absolutely a risk factor for suicide in carers, as it is in the general population. But not all carers who think about suicide are depressed. And I'm going to say that again because it's so important. Not all carers who think about suicide are depressed. So it's really important to treat depression in carers, absolutely. But it's important that we don't just medicate carers for depression and then send them back to care, because that does little to address the broader social and political factors that contribute to suicide risk in this population. So I think the message here is that it's really important that we don't pathologize suicide risk in carers as just an individual mental health problem. It's so much more complex than that, and we're never going to be able to prevent suicides in carers if we're only tackling one piece of the puzzle. So the factors that are on the slide here are the things that were really consistent when we looked across all of these 45, 48 studies, however many it was we had. These are things that came out time and time again. There wasn't really any consistency in terms of the relationship between the carer and the person they were caring for, how long the person had been caring for, or their gender. So we couldn't really make any consistent statements there. Things that were starting to emerge, though, that we think might be quite powerful, is that the severity of the illness might play a role. So people who are caring for family members with more severe or profound illnesses may be more likely to think about suicide, as are carers where the illness or condition is attached to a lot of public shame or stigma or misunderstanding. We're also starting to see that carers who are struggling with their own physical health problems while they're caring for someone else are also more likely to think about suicide. And we're also starting to see some differences across countries. So in countries that have genuine universal healthcare, and I'm not including the UK in that list, that may reduce the risk for carers having access to genuine universal healthcare. Also in countries and cultures that have filial piety, so where there are particular rules about how care is provided or who provides that care, that may actually place people at greater risk, particularly when you think about dissatisfaction with the role, conflict, or being trapped. In terms of homicide, it's harder to determine risk and protective factors for homicidal thoughts because there've only been a few studies and they've all been qualitative. But what we know from those and from studies of deaths by homicide and homicide-suicide is that there are four main reasons that carers think about or actually end the life of the person that they're caring for. So some carers who think about homicide or who act on those thoughts do it because the person they care for is suffering and has little or no quality of life. And often in those cases, it's because there's no opportunity, there's no other, there's no access to a dignified death. We also know that some carers do it because they're unable to continue caring due to exhaustion, emotional distress, or financial problems, for example, and they don't see that there's anyone else who's going to provide that care. We also know that some carers who think about homicide or act on those thoughts do it in order to preserve their own life, particularly if the person they care for is violent or is experiencing serious mental illness. Some carers also think about homicide or act on those thoughts in response to a crisis that's actually unrelated to the caring role, but that pushes them beyond what they have the capacity to cope with. And that lack of capacity, that reduced capacity, is the result of years of caring. We also know that in the majority of homicides and homicide-suicides perpetrated by carers, there is no history of domestic violence. And I'm going to repeat this one again because this is really important. So there are absolutely a handful of homicides and homicide-suicides perpetrated by carers that are about abuse, neglect, fraud, things like that. Absolutely. So I'm not discounting those. But the point I want to make really clearly today is that in the majority of cases where a carer kills the person that they're caring for, either alone or then kills themselves, there is no history of domestic violence. So now that we know that carers are a high risk group for suicide and homicide, and I think we can say that very clearly from the evidence that we have, what can we do about it? So in terms of policy, I was very tempted today to scrap this slide and just say, let's have a functioning government. But assuming that we will have one of those in the future, let's talk policy. So we need to recognise the social and economic value of unpaid care, and we need to recognise carers as experts by experience. And once we've done that, then we need to reward and compensate carers accordingly. Carers shouldn't be living in poverty, and they must have a voice at the policy table. We also need to develop and fund evidence-based policies and programs specifically for carers, and not simply have carers as an afterthought or an addendum to other policies and programs. And this absolutely needs to include access to regular, funded, and high-quality respite care. We also need to reduce the administrative burden on carers so that they're not constantly having to do battle across multiple agencies and services to get the basic needs of the person they care for met. And in that same vein, we need to improve support for people with disabilities and long-term illnesses, because much of the work that carers are doing is picking up the slack of a failing health and social care system. And I would add there that we also need to ensure that residential care, and that's not just aged care, but definitely includes aged care, is affordable and high quality, so that there is a real alternative when caring at home is no longer safe, sustainable, or appropriate. In terms of practice, and I'm going to use this term really broadly here to think about health and social care, local authorities, charities, and other third sector organisations, it's important to understand that carers who are thinking about suicide are in crisis. And what they need is support, not shame or judgment or the threat of persecution or prosecution, but understanding and support. So how do we do that? So first, we need to ensure that anyone who has contact with carers is trained to recognise and support carers at risk of suicide or homicide. We know from our review that health and social care professionals are encountering at-risk carers, but many of them lack the knowledge and the resources to support them appropriately. And there are some existing suicide prevention training programs. So some of you will have done ASSIST or mental health first aid. Others of you will have had modules on suicide and other mental health issues in your professional qualifications. But all of those programs and all of that education was developed before the evidence on suicide risk in carers became about. And what that means is that most suicide prevention training is based on supporting a single individual at risk of suicide. But we know that carers come in a set with the person that they're caring for. So in thinking about how to support a carer through a suicidal or homicidal crisis, we also need to ensure that professionals understand how to support a vulnerable care recipient as well. So sessions like this are a really good start, but we also need to develop dedicated training programs informed by this new evidence. Second, we need to ensure that when people take on a caring role, so when their partner becomes disabled, when they, they give birth to a child with special needs, whatever the situation is, there's some sort of screening for pre-existing physical and mental health problems that might be exacerbated by the caring role and then place people at risk of suicide. And once we've done that screening, we need to ensure that those carers get proactive support for those existing physical and mental health needs. We also need to ensure that all carers are routinely assessed for thoughts of suicide and homicide, not just carers with symptoms of depression and anxiety. As part of that screening and assessment, but also in online communities and third sector organisations, we need to create safe spaces where carers can share thoughts of suicide and homicide without fear of prosecution, unnecessary sectioning, or having the person they care for removed. And I should say, having done research on this topic for more than a decade, those are the two biggest fears that carers have when disclosing thoughts of suicide or homicide, that they'll be sectioned or that the person they care for will be taken away. And while in some cases that may absolutely be the best course of action for everyone involved, in most cases, all carers want and need is to be able to safely offload these thoughts. Then, of course, where carers do share thoughts of suicide or homicide, we need to ensure that they have access to dedicated services and support. And what's really important to note here is that just as existing suicide prevention training programs don't account for caring, many of the charities and other organisations that support carers aren't equipped to handle suicide or homicide risk. So we need to be thinking about which organisations and which professionals are best equipped for this and refer carers accordingly. And finally, as I flagged earlier, although it's vital that we support carers in crisis, we have to balance this with our obligations for safeguarding vulnerable people receiving care. And we need to be working towards the best outcome for both the carer and the person receiving care. So what's really clear in this review that we did and in all the evidence is that there is more than enough evidence now to be acting in policy and practice to support at-risk carers. I don't think we need to be waiting to take these steps. But there is still a need for more research. There are still gaps in our knowledge. And so I want to talk a little bit now about research. So one of the first things that we need is dedicated studies. So many studies in our review had suicidal thoughts as a secondary focus or sometimes even an incidental finding. But in order to truly understand this phenomenon, we need more studies where the investigation of suicidal thoughts and behaviours in carers is the primary aim. There's also a need for some dedicated studies on groups of carers that haven't been a focus of research yet. So I'm thinking particularly here about young carers and ageing parents of adult disabled children. We also need longitudinal research. So we know that carers experience suicidal thoughts and behaviours across the caring journey, including after the person they care for has died or moved into residential care. But we don't know if there are specific points or experiences or transitions in the journey that might place carers at greater risk. If we knew that, we might be able to put some additional support in at those times. So definitely longitudinal research. We also need comparative studies to look at how suicide risk varies across countries and cultures and different illnesses and disabilities. I should point out there that what seems to be becoming clear in some work we're doing at the moment is actually that the specific illness or disability probably isn't actually the issue. The bigger issue is the symptoms of that condition and how that condition is perceived in society and how it's supported or not. As I flagged earlier, we also need systematically collected data on attempts and deaths by suicide and homicide-suicide. And probably most importantly, we need a greater emphasis on the lived experience of carers. So some of you will have noticed that although I said at the start that all of our research has been done in partnership with carers, those carers' voices haven't been anywhere in this seminar today. That was a really deliberate choice today, and I'm really happy to talk more about why later on if people are interested. But the key message here is that carers' voices must be at the forefront of this research, and any research on suicide and homicide risk has to be co-produced to ensure A, that it's meeting carers' needs, and B, that it's ensuring that they feel safe to participate in research on this topic. And I'll talk a little bit more about safety in a second. And then the last thing here in terms of recommendations for research is that our review didn't identify any intervention or prevention initiatives for carers at risk of suicide or homicide. So there's a need to develop and evaluate dedicated programs for at-risk carers. So at this point, we're going to move slightly to a discussion, but I just wanted to dispel a couple of myths or objections that we often encounter when we're doing this research or we're seeking to inform policy and practice in this space. So the first one is that this research is dangerous, that asking carers about suicide or homicide will put ideas in their head or prompt them to act on existing thoughts. So let me be really clear, there is no evidence to support this. And all the evidence says that if it's done appropriately, and obviously that's a really important caveat, if it's done appropriately, asking people about suicide and homicide is actually cathartic and it leads to help-seeking behaviour. And from all the studies that I've specifically led on carers, we know that for many carers, our research is the first time that anyone's ever asked them about thoughts of suicide or homicide. And there's tremendous relief in having been given a safe, non-judgmental space to talk about them and to have these experiences seen and normalised. The second, I guess, barrier that we often hit with this work is the idea that deaths by suicide and homicide are rare, and so there isn't really an imperative to support carers. My response to that is that, first of all, in the absence of more data, we can't actually say anything about how rare or otherwise deaths by suicide and homicide in carers are. And second, it's inhumane to suggest that we should wait for carers to die before we act. The fact that carers are contemplating suicide and homicide is a really clear sign that unpaid care in its current form is unsustainable and that the support we provide for carers is woefully inadequate. So what I would like to do now is really open it up to you. I would love to hear your questions, your comments, your reflections, your thoughts. If you're in practice, does this resonate with you? What challenges might you anticipate in starting to support carers? If you're in a research setting, what opportunities do you see here? What concerns would you have about doing this kind of research? It's really an open floor. So thoughts or comments. I can see Claire's already. So Claire, do you want to start?
Thanks. Excuse me. Thank you, Siobhan. That's really interesting. I've got a couple of questions. The first was, in the myth busting at the end, one of the difficulties with this type of research is getting it through ethics committees. And I just wondered about your thoughts on that. The second question was why you'd excluded the carer's voice from the systematic review. Yeah.
So let's do that one first. So not actually excluded from the systematic review, just excluded from this presentation. And the reason for that is that there's two parts. One, our carers do a huge amount across our various projects, and recently they've been part of lots of webinars and presentations and other things, and it felt like this one was just one too many to ask for. The other reason is that obviously when carers share their experiences, particularly in these sorts of public forums, there's a risk that they are identified or that someone in the audience feels that they have an obligation to make a safeguarding referral. And so we always have to weigh up that decision here of is it worth the risk for that individual carer to share their story as part of this seminar. So that's why not today. But in terms of the research, those voices are absolutely there, and the carers have been part of everything that we've been doing and really the key to making sure that this research is getting out there and being done safely. In terms of ethics committees, with patience and great attention to detail, I would say, is the way that we get this through ethics committees. We've been doing this for quite a while now, so we have really clear, very detailed protocols about how we do this research, what happens if we think someone is at risk, safeguarding protocols, all of those sorts of things. We also work with clinicians, so social workers, psychologists, psychiatrists, who have mandatory reporting requirements as part of their professional practice and are very well trained at handling these situations. And I think that gives ethics committees a lot of confidence in the safety of the work. I also think because it's developed in partnership with the carers have been very clear about what would make them feel safe in these studies. And so being able to say to an ethics committee, actually carers have told us that this is how they want us to do this, has been a real strength as well. But overall, my experience has been that ethics committees absolutely see the value of this research and they want this research to be done, and they're really happy to work with us to make sure that we have a framework that can do it safely.
Thanks, Siobhan. That's really, really encouraging, because at one time they were very risk averse, going back a decade, I'd say. So it's good to see that it is valued, and great work. Thank you.
Thanks.
Yeah, so Helen, oh no, I've just lost it in a sec.
But yeah, we've thought about this for quite a while in our teams. I work clinically, and you know, we mentioned in training, it's such a tough question to get to, asking somebody about thoughts of homicide, but yet really essential. And I wondered whether people had any really skillful ways of asking about it. I mean, I've thought about, you know, we normalise and might say something like, many people in your situation might struggle with thoughts of harming themselves, killing themselves, or ending the life of the person they love. But I don't know whether there's any more skillful ways to pose that difficult question.
No, I think you've nailed it, Helen. That's often how we ask it in the research, is that normalising. It is saying, okay, here's what we know. We know lots of carers feel this way. We know these are the different reasons that they might feel this way. Does this resonate for you? Have you ever felt this way? So that's a really nice way to lead in. I think what's important, and I'm sure you do this in your practice as well, is that in the research that we do, when we ask that question, we're often sort of 45 minutes into a conversation,
Yes.
which can be hard in clinical practice when you don't have 45 minutes to warm up to that question. But I guess then it's about building those relationships long term with carers and clients, so that trust is there when you do feel that you need to ask that question. Yeah, you've got that rapport already.
Thank you.
What I would say too, Helen, I can see in the chat that you've asked about about Thomas Joyner's work. So for those of you who aren't familiar, Thomas Joyner is a suicide researcher in the States who came up with sort of a new theoretical approach to suicide based very much on a family experience of his father dying by suicide, which has some interesting relevance for carers, but not all of that theory maps onto carers' experiences. But he also wrote a book, as Helen's pointed out, called The Perversion of Virtue around murder-suicide, which I have to admit I threw at the wall the first time I read it. I was not particularly impressed.
Okay.
But I think, again, it's coming from that non-caring perspective, and I think a lot of the evidence is around homicide suicides that happen in the context of domestic violence or abuse or neglect or other things, and I think that's probably why it doesn't fit quite so well on the caring experience. But I think there's definitely things to be learnt from Thomas Joyner, and then to advance that work as well going forward.
Yes, thank you.
That's okay. I should point out too, someone before, I'm not sure if it was Claire, someone used the term loved ones as well, and I need to make a really important point here that not all carers do it for love. Not everyone who's being cared for is loved in the context of this relationship, and it's a really important thing to keep in mind. Of course, the vast majority are, but some people are very much pressured into that caring role. They might be caring for someone who has been abusive to them in the past, and it's really important that we don't assume love as the underlying motive for caring.
Hi, Anne, did you want to ask a question? I work, my colleague Pen is here as well, and I work with Helen Lee Savage, who's here, and we're very aware that in Cornwall at the moment, though we have yet to reach inquest and have a conclusion on many deaths, inquests are delayed, But anecdotally, we are aware that we're seeing an increase in deaths of elderly people. And by elderly, I would say post 75. And those deaths are suspected suicide. And some of those deaths may be related to where they have been carers or have long-term illnesses. So I think your research is really relevant, but given that we don't seem to have a prime minister at the moment or a government, I do think there is an urgency. And I think that these increased numbers of suicide amongst the elderly population, which I've never witnessed before in such large numbers. And of course, in Cornwall, we have larger than the average elderly population, is probably a result of the pandemic. And when I've made phone calls to adult social care to make a referral, I'm frequently told we're very short of staff at the moment. There's going to be a delay of being able to put carers in place. And we're having to ration those carers because we have a shortage of staff. And that's partly due to Brexit, partly due to the pandemic. So I think there is an acute time bomb ticking away here. So your research is timely, but somehow it needs to be prioritized. So perhaps somebody like Ian Sheriff, who chairs government committees, could put a bomb underneath them. I don't mean that literally, but get things moving. Or we'll see more deaths.
Yeah, I absolutely agree with you, Anne. And I think you know, COVID, absolutely, you know, the reduction of services, people being isolated in their homes with the person that they're caring for, and then those services not being returned. One of the things we often hear carers say is, you know, they're too terrified to tell anyone that this is how they're feeling. But then for the odd carer who has told someone, nothing happens. And I think that's even more terrifying. In terms of the deaths, the other thing that often happens is you see inquests or serious case reviews or domestic homicide reviews, other things like that. And when you read those reports, they often say, oh, this was an isolated tragedy that couldn't have been predicted or prevented. But what you see when you look at all of these cases one after the other is that they're not isolated, and they absolutely could have been predicted. Well, some of them absolutely could have been predicted. Many of them could have been prevented if there had been sufficient support and understanding beforehand. I think also I mentioned at the start about, you know, using these terms suicide and homicide and not using terms like murder or mercy killing, or because often there's this misunderstanding, particularly with older adults. There's almost a romanticizing of these things, particularly when there's a homicide suicide of, oh, well, you know, bless, they went out holding hands, and isn't that romantic? And no, it's tragic. It's horrific that an elderly couple, for example, might feel that this is their only option, or be forced to that point. I think the other thing that you mentioned too, Anne, that's really interesting is Cornwall. And I think we know with a lot of this work, you know, carers who are in rural or regional places with limited access to services, limited public transport, those are always going to be a greater risk area, absolutely. And I think you're right, there's absolutely a need now to start rattling some chains and getting people to take this work seriously. And so I think that policy briefing is the first step in starting getting that shared widely. And there has been recently quite a bit of interest from some local authorities and other groups who realise that they're not getting it right. So that's really positive. But you're right, we're going to see, I think we will absolutely see more deaths before we get people to take this seriously, and that's heartbreaking.
I've got a question for you though.
Mm-hmm.
That's okay. So you mentioned that talked about this not being like a UK problem, particularly it's a worldwide issue. Mm-hmm. Do you find that there are higher proportions of carers in environments or cultures where the extended family is part of culture, and so I guess do you get a high proportion of carers in those situations, and does that have an influence on whether people are more likely or not to feel suicidal or have those suicidal thoughts?
Yeah, I think it depends on there's not enough research yet to make those really sort of clear statements about those sort of differences. But what we're starting to see and get the sense of is it depends what that extended family is doing. If they're actually supportive, if they're all pitching in, if everyone has a role in the caring, then absolutely that's a great thing. If, as you often see in some communities, it's some, to do all of this work and put up and shut up, then it's not going well. So it really is about those family expectations. And also I mentioned that family conflict. So if there is conflict in the families about who's providing the care, how it's being done, particularly if there's an estate, if there's money involved and there's conflict about selling the house, for example, those things really take a toll as well. But there isn't enough evidence yet to be super clear about, okay, which context, which countries. The other thing I would add that wasn't in the review, but that we're starting to get a sense of as well, is obviously around methods and the differences in countries where there is access to firearms. Easy access to firearms obviously is going to make a huge difference in this context as well.
Hi Siobhan, brilliant presentation. I was jumping between devices, so sorry if I missed it, but I wondered if you thought or there was any evidence of an increased risk of suicide during the pandemic, when we know particular parent carers were even more stressed.
No, so actually, if you look at so Lewis Appleby's a suicide researcher, probably the most prominent one in the UK, and he's done a lot of work looking at suicide risk in general across the pandemic, and certainly in the early stages, actually, it wasn't increased, but obviously that work doesn't take into account carers, and so I think the situation is going to be very different for carers than for the general population, and I would bet money on the fact that it's increased for carers. Certainly in the work that we're doing on parent carers at the moment, parent carers are absolutely citing the pandemic as an extra source of pressure and stress and an extra factor that's leading to these sorts of thoughts. Yeah, definitely.
It's a brilliant presentation.
Thanks. We might just do Penny, and then I'll move on to a few final comments before we need to go. Penny.
Yeah, hi. I just wanted to ask, how do we promote a culture where carers feel able to reach out for support? Because I don't know whether it's just my assumption that lots of carers act in isolation and aren't engaged with other services. Where my service, I work with Anne, suicide liaison service in Cornwall, and we only come in the aftermath of a suspected suicide, where we would ask all these questions. But I'm very aware that carers can feel very isolated and aren't engaged with anybody. So how do we promote that culture where they can come forward themselves and say, look, I'm having these thoughts and I'm really worried about it? Yeah. As well as, yes, obviously other services being involved and asking those questions.
Yeah, I guess my feeling would be that it's everyone's responsibility, that we need to make sure whichever door a carer knocks on at that point, that they get a safe, supportive response. So if they go to their GP, they get that. If they go to a carers forum, they get that. If if they're talking to someone at this, their child's school, for example, they get that support. So I think making people aware across the board that this is an issue and getting people skilled up. I would say the other thing too, more generally, is what we often see with carers is that they encounter so many roadblocks along the way, and they develop a bit of learned helplessness, I think, of just going, well, what's the point in asking? Because every other time I've asked, or I've told someone I was struggling, they didn't do anything, or they just gave me some antidepressants and sent me home. So I think there's a broader issue here in terms of supporting carers that would create a culture where carers did feel safe to share this stuff. Absolutely.
Yeah, and this is why your research has been so valuable, and making sure that gets out to these agencies, Carers UK and other services, so that they're fully aware of the importance of your research. Thank you.
And I think there is also a place, like you're saying, for sort of, post-vention services as well, to make sure that whatever we're learning after attempted suicides or after deaths by suicide is then being fed back into the to the work we're doing in terms of prevention. So I think those sort of post-vention services are vital.
Thanks very much. Thank you.
So I just wanted to talk quickly about next steps. So in terms of where we go from here, as Chris mentioned, we're currently doing a study called the Parent Carer Wellbeing Study that is looking at the risk of suicide, homicide and self-harm in parents caring for children with disabilities. We've had about 800 parent carers across the UK take part in that, and we actually finished the data collection yesterday. So we're hoping that come January or February, we'll have some really clear evidence on what these issues look like in parent carers. We've also been funded by the Devon Partnership Trust to develop a typology of carer-perpetrated homicides. So to start to understand more about those different motives behind the different homicides and how they can be prevented. The other thing I'd say in terms of next steps for all of you, and also for me after this, is a little bit of self-care. So this work is really, really dense, really heavy, really complex. And even just listening to these things and thinking through what it means for you and your practice can really take a toll. So I'd really encourage you, buy yourself something nice for lunch. If there's sunshine where you are, get out and go for a walk. Just take some time to do some self-care after this session. And then the final thing to say, and I will put some links in the chat when I close the slides, is that if you do want to know more, or you would like to start using some of this evidence to strengthen your work, whether it's in lobbying or policy or in clinical practice or social care, myself and the team that I work with are really happy to help you do that and to spend time with you and think through all of these issues and share what we've learnt, if it's helpful. So my contact details are there on the screen. I'll also ask Becky to circulate them after the session. And so please do get in touch if we can be of any help with this. And then also, again, just to say, on a really difficult day for everyone to come and to listen to this, I'm really grateful. I'm really grateful for all the interest and enthusiasm, and hopefully together we can start to do some really good work in this space.